writing in the మన వీడియో రైటింగ్ పర్లేదు ఓకే స్టార్ట్ చేయాలి. So good afternoon everybody. Today we're going to be discussing CNS infections. So we'll be doing this in two parts. The first part will be looking at the basics of CNS infections in the part 1. Slides in the order. Okay, I think I'll start. Right. దీనికి 5 seconds దీంట్లో మన స్క్రీన్ దీంట్లో రావాలి కదా, నేను కనపడట్లేదు అక్కడ కనపడలేదు. Start. So today we'll be discussing about CNS infections, and part 1 will be discussed today, and the part 2 will be discussing on the next week. So in this session, we're going to be discussing the major definitions of CNS infections, the etiology, clinical features, and if possible, workup and MRI patterns will be discussed in the next lecture. So it's a very common topic, that is CNS infections are very common one in India and other developing countries. I mean, so we have a lot of confusion regarding what needs to be the exact term which we use for CNS infections. So CNS infection is a very broad term wherever you are in the world. But the term acute encephalitis syndrome is basically a term which has been introduced by the World Health Organization in the context of the Indian scenario of surveillance of Japanese encephalitis. So from this point on time, the term AES was actually used, but the term AES is actually not globally accepted. It's not used in other countries, specifically in India. in the context of WHO. So when you're not sure whether it's an infection related to bacteria, virus, is it meningitis, meningoencephalitis, we're not sure about it, a broad term of CNS infection would be very apt. Encephalitis particularly means, as the name itself says, that there's parenchymal involvement. So there is encephalitis, that is, there is an infection of the brain parenchyma which is actively going on. So the criteria here is basically you need to have an acute onset fever and encephalopathy. So encephalopathy can be in the form of altered sensorium. It can be in the form of coma. It can be in the form of seizures. So seizures are not mandatory. So with or without seizures, with a fever should be the criteria for encephalitis. And the other causes of neurological signs of CNS inflammation should be ruled out. For example, the infective, non-infective causes like toxic ingestion, all that should be ruled out before labeling it an active infection. And also, it's very important for you to know what is encephalopathy. Encephalopathy is basically a non-inflammatory pathology. It can be biochemical, and hence it's when you're not sure whether this altered sensorium or seizure, which is happening, is not because of an infection, or at this point you don't have enough evidence to say it's an infection. It's better to use the term encephalopathy. So, for example, it could be a drug ingestion, it could be uremic encephalopathy, it could be hepatic encephalopathy, it could be, any other toxic ingestion or lead encephalopathy. So it's basically a non-infective or a non-specific cause which is causing altered sensorium or seizures. So when you're not sure of an infection, temporarily you can label that as encephalopathy, and maybe you can start thinking about infection if there's a history of fever. Maybe consider an MRI and maybe do a CSF and document the infection and then label it encephalitis. So this is broadly the terms which are used by the WHO, that if you have only parenchymal involvement, it's better to use the term encephalitis. When you have only meningitis, you use the term meningitis. And when you have the combination of both, it's better to use the term meningoencephalitis. Or a CNS infection in the broad is also pretty good enough. So in the category of meningitis, you'll have more of altered sensorium, meningeal signs, and stiff neck and photophobia and fever. On the other hand, if you have encephalitis, if you have fever, altered sensorium, more of parenchymal features, focal signs, comatose condition, and new onset seizures, then start thinking of encephalitis. Whereas in contrast to meningitis, you have more of the meningeal signs itself, like neck stiffness, photophobia, meningeal signs would be there, and you have fever in both the conditions. So we have combination of that can have meningoencephalitis, what we typically see in tubercular meningoencephalitis. So this is about the definition. And if you see, the WHO definition is pretty non-specific. We are not having any investigations of confirmatory features. So if you actually see demyelination, ANIC, ADEM, they'll also fall into the criteria of AES according to this definition. So that's why they've actually tried to be more specific. And this is a definition which was introduced by the IEC, that is International Encephalitis Consortium, in 2013. So they have introduced something called a major criteria and a minor criteria. Major criteria includes neurological dysfunction that can be in the form of altered mental state, that is altered sensorium, which should be lasting for at least more than 24 hours without any alternative cause. So this is a very important feature. If you have an alternative cause found, you can't include that in encephalitis. And minor criteria would include fever more than 38, new focal neurological signs, and CSF abnormalities, and cranial imaging parenchymal changes. This is ideally an MRI, and EEG findings consistent with encephalitis. So typically, these are included as minor criteria, and you have major criteria in the form of altered sensorium for more than 24 hours with alternative cause being ruled out. So based on these major and minor criteria, so there are definitions of the few definitions of AES. There is one thing which is called definitive AES. So definitive AES is basically there should be the isolation of the bacteria or the microorganism you're suspecting. So that can be in the form of a culture, it can be in the form of PCR, it can be in the form of metagenomics. So identifying the exact organism will become the definitive AES. Or if you are thinking it is autoimmune encephalitis, you need to have a laboratory evidence of autoimmune antibodies being positive. Or if you have a pathology specimen, or maybe postmortem, or you do a brain biopsy and the biopsy shows there is some sign of encephalitis, autoimmune encephalitis, and that is also a definitive AES. So AES could not only be infective, the definition doesn't say that no, it's particularly infective, because you need to have acute onset fever, altered sensorium with or without seizures, according to the WHO. So that can be there in autoimmune encephalitis as well. So very well remember, autoimmune encephalitis can be part of acute encephalitis syndrome. Confirmed AES, on the other hand, is basically, this is more like the criteria, major and minor criteria. So presence of major criteria, that is altered sensorium more than 24 hours, with 3 or more minor criteria. So minor criteria, as I said in the previous slide, it could be fever, it could be CSF abnormalities, it could be MRI findings, it could be new onset focal deficits. So all these 5 minor criteria I was discussing in the previous slide. And the final one is basically the EEG findings. So EEG, MRI, and CSF 3111, new focal findings, and fever more than 38. So if you have more than 3 criteria, minor, plus the major criteria, that will become your confirmed AES. Okay. Then if you have only one major criteria, that is major criteria, that is altered sensory for more than 24 hours, and 2 minor criteria. So that could be possible AES. So these are few of the definitions, but again, clinically, you can just label them as CNS infections. This is the most important aspect, that is etiological aspects. This slide per se is extremely important. So whenever you approach a case of acute encephalitis syndrome or a CNS infection, it's very important uh, to revise the history, because it's always in the history. The story is always in the history. So we do have a lot of advanced tests nowadays, that we have metagenomics coming up, we have multiplex PCR, biofire. We try to identify the exact organism. But despite any sort of advancement you see in the medical science, the history still remains the most crucial aspect here. So the onset of symptoms, that is uh, based on the onset, for example, the history of fever and the altered sensorium. So the parents come to you and say that there's on and off fever going on since 3-4 days, and the child has been irritable since last 2 days. So that is more like an acute or subacute picture. So usually acute is somewhere between 0 to 5 days. The first week, the child has on and off fever. In the last 2 days, the fever spikes have gone high, and the sensorium has actually dipped in the last 2 days. But since the last 5 days, the parents also noticed that it was drowsy. So this is the typical acute picture, what you see in bacterial meningitis. Okay. And there's another type of presentation which is called hyperacute, which is not depicted in this picture. So the typical history, what parents tell you is that my kid has gone to the school. She was perfectly all right. She had her dinner and she slept. And the next day she woke up, she was totally encephalopathic and she was in altered sensorium. So this hyperacute presentation. So hyperacute presentation is typically seen in neurologically whenever you have something very hyperacute. Either it's vascular or it could be a viral, devastating viral infection. So viral encephalitis can have varied presentation. It can also have a very devastating time of acute or hyperacute presentations. So overnight, everything happens. So that is a typical picture in viral Japanese encephalitis, especially enterovirus encephalitis. Even herpes also has a very rapid onset progression sometimes. So hyperacute is viral, acute is bacterial, and then comes subacute. Subacute is basically something more than 5 days and something less than 3 weeks. So 3 to 21 days approximately. So here the typical history goes like, the parents. So usually it's like a neglected child. The child has on and off fever since last 3-4 weeks. The parents say that fever will come, will go, he'll respond to antipyretics. The fever is not pretty continuous. The fever is very low grade. So all this is kind of history. The child is very little irritable. The history goes on for 3 weeks, and since the last few days, the child has been excessively irritable and the fever spikes increase. So that is when they come to you for the hospital. So this is the typical subacute kind of presentation. What you see typically in tubercular meningoencephalitis, a very common cause in India. Whenever we have subacute onset, 3 weeks, 2 weeks, slow progression, think of tubercular meningitis. And also remember, autoimmune encephalitis also falls into a subacute. So in autoimmune encephalitis, typically the patient presents to you, there's the history of a previous preceding prior fever, and then after a couple of weeks or 3 weeks or 4 weeks, then you have sudden onset or sometimes subacute onset behavioral problems, neuropsychiatric manifestations. The parents notice that the child is not interacting anymore; is more calm, dull, or sometimes have bursts of emotional outbursts. And sometimes the parents also notice that sleep disturbances. And eventually, they come to you with seizures, and eventually, if not treated, they become mute and they also become hemodynamically compromised. That's the typical history you see in autoimmune encephalitis. But in the typical stage of neuropsychiatric manifestations, also remember autoimmune encephalitis has this very specific feature called perioral dyskinesia, that is orofacial dyskinesia. You have a pouting type of movement, lip puckering movements. So all these sort of perioral movements are very classical in autoimmune encephalitis. So this is again falling into subacute category or chronic category, sometimes in chronic. And coming to chronic category, that is more than 21 days, you start thinking of other rare causes like fungal meningoencephalitis and cryptococcus is very common. Again, you'll have a background here because cryptococcus is not that common. You should have an immunodeficiency or maybe HIV, or the patient should be on long-term steroids or on some chemotherapy. So this is about the infections, and you need to think accordingly. And there's a criteria. There's a typical group of infections wherein the timeline of injury is not very specific. For example, if you say rickettsial fevers can have acute onset, subacute onset, sometimes even chronic onset. Malaria typically has acute onset. Brucellosis can sometimes have chronic onset. Cryptococcus typically has chronic onset. And non-infective immune-mediated causes can also have acute onset. For example, ADEM, NMOSD, ANIC, they have very severe acute, hyperacute type of presentations. And also remember the last two things we have to remember here. Very rare causes, there's a variant of GBS called Bickerstaff encephalitis, that brainstem encephalitis can also present as AES with altered sensorium and focal deficits. And a new emerging entity called FIRES. FIRES is basically a febrile infection-related epilepsy syndrome that is a part of NORS, new onset refractory status epilepticus. This typically follows after a fever episode. The child will have refractory seizures. So this entity with seizures can also sometimes have altered sensorium with it. So a common DD in the category of AES. And the final one you have to remember is inborn errors of metabolism. So this needs to be suspected the child is less than 2 years. So most of the small molecule IEMs will present within 1 year. That is almost 90% of them. And 95% to 98% of them present within 2 years. So there are only few types of small molecule IEM which present later on with acute onset encephalopathies. So these are inborn errors of metabolism wherein there's an intercurrent illness, it's a febrile illness, and suddenly they decompensate and they present you with encephalopathy or seizures. So when this episodic decompensation, which is happening in the background of a global developmental delay, in the background of a consanguinity, start thinking of inborn errors of metabolism if the child is less than 2 years. So these are all the varied etiologies of acute encephalitis syndrome you need to think when the child comes to you with this history. I'll not go into the details of it. You must be knowing this is a common five. Common is they call it the big five in India, and not only Indian, across India as well. So Haemophilus influenza, Streptococcus pneumoniae, Neisseria meningitis, GBS, and Listeria monocytogenes. These are the five commonest ones. Listeria is not that common in India. I think Klebsiella should be way more up in the list, in the etiological list of bacterial meningitis. And according to the age as well, if you see the more the age is more than 3 years, more than 5 years, you have more incidence of meningococcus. So if you see more than 10 and less than 19 and more than 3 years, meningococcus is actually higher percentage. And the incidence of Streptococcus pneumoniae and Haemophilus influenza is also coming down because of the vaccination, increased vaccination cover of PCV and also Hib. So now the Klebsiella is on a rise, and gram-negative bacilli is also very common. Staph also is pretty common in meningitis nowadays. So again, why is it so important to know what bacteria is it? First is you need to know the exact bacterial antibacterial coverage you want to give. And the second thing, you need to know the duration of antibiotics actually depends on what type of organism we are dealing with. So there are certain clues onto the background to suspect what organism is it. So more often happens that culture doesn't pick up. The yield of sales of culture is extremely low, 20 to 30%. If you see biofire, that is multiplex PCR, the common pathogens which are tested, the sensitivity increases up to like maybe 60, 70, sometimes 80%. But I think nowadays we have metagenomics. The sensitivity even increases up to 95%. So again, depending on the age, less than 1 month, the neonatal bacteria, that is Klebsiella, GBS, E. coli, Listeria, these are common in the newborn age group, that is late onset sepsis. And in the infancy, again, the same groups, Streptococcus pneumoniae, Haemophilus influenza, E. coli are common. And after that, more comes your meningococcus. And also remember when there's a history of basilar skull fracture, remember Streptococcus pneumonia. Haemophilus influenza, that is especially from the ear cavities and the ear infection going inside. There is a chronic otitis media, then causing mastitis and then spreading into the brain. That, and again, you have to start thinking of Haemophilus and pneumococcus. And you have penetrating head trauma, especially in road traffic accidents. There's an open skull fracture, and followed by that, you have meningitis. Obviously, the contamination of the skin will go into the brain. So start thinking of Coagulase negative staphylococcus and other anaerobic bacteria. Post neurosurgery, especially after BP shunt placement, start thinking of Coagulase negative staphylococcus, that is Staphylococcus epidermidis and Saprophyticus. And again, CSF shunt infection, very common, Coagulase negative staphylococcus. In fact, in any plastic or any adhesives or any cannulation, long-term PICC lines, these common infections need to be suspected. And accordingly, the antibiotics should be tapered. And the duration also depends on the organism. So these are uncommon causes. We have discussed the common ones. In the viruses, you have the commonest ones across. I'll discuss what are the common ones. If you see the causes of encephalitis, the commonest ones across the globe is herpes encephalitis, and followed by that you have enteroviruses, which are common across the globe. In India, particularly Japanese encephalitis and dengue are most common in India. Apart from that, you have paracoviruses, influenza virus, Epstein-Barr, cytomegalovirus, varicella zoster are also common. Amongst the bacteria, apart from the top five we have discussed, Mycoplasma pneumonia in particular seasons is very common. You know that in the last few years, Mycoplasma has gone into a very spotlight, that we start thinking about Mycoplasma in the setting of pneumonia, long fevers, and even it can also cause a lot of CNS demyelinations, MERS, and also encephalitis as well, even vasculitis, CNS vasculitis. So less common causes, again, Bartonella, not that common. Rickettsial infections, again, common in certain parts of India in certain seasons, especially in the northern India in particular seasons. Rickettsial fevers are very common. The commonest rickettsial fever in India is scrub typhus. They're typically present with fever and erythematous rash. Lyme's disease, again, not that common in India, common in the United States. They present to you with fever, erythema chronicum migrans, that is bullseye rash or target rash. Then you have arthritis, then you have CNS infection and cardiac involvement. Then coxiella burnetii, that is Q fever, again, not very common. These are other common infections with uncommon infections. Again, in India, tuberculosis needs to be on the top whenever we have subacute to chronic onset meningitis or encephalitis. These are some of the less common causes, that is hepatitis E, HIV, measles, mumps. I think in the past 1 year, we had an epidemic of mumps virus infection, that is, because of the vaccine change from MMR to MR. Mumps encephalitis, we had a lot of cases in the last 1 year. Powers B19, again, not very common. Rabies, sometimes it's sporadic, it can happen. Rubella, very rarely. And tick-borne encephalitis, you see now and then, not very common in India. As I said, fungi, Cryptococcus neoformans, in the background of immunodeficiency, it's very common. And parasites, Toxoplasma, again, needs a background or an exposure to cat feces and pregnancy, and also some of the immunodeficiency conditions. And Plasmodium falciparum is a very common condition in India, that is cerebral malaria, needs to be considered in a common state where malaria is endemic. Naegleria fowleri and Acanthamoeba are very rare. They are called primary amoebic meningoencephalitis. With the history of free water swimming, the parasite actually goes into the cribriform plate and enters into the brain. That's necrotizing encephalitis. It's not very common. There are only 300 cases reported, very less reported from India. And I think that needs to be in the bottom of a differential diagnosis. So coming to the scenario in India, if you see, the commonest viruses are dengue and Japanese encephalitis, followed by scrub typhus. Now and then you have outbreaks of chikungunya, leptospirea in the border of Sri Lanka, West Bengal, and the other infections nowadays, scrub typhus in northern India, UP and Delhi have a lot of scrub typhus. But most of the South India we have in Karnataka, Japanese encephalitis is pretty common, and across the India, dengue is very common. And in the northeastern parts of India, we have a lot of cerebral malaria still happening there. So these are the states which are affected with maximum number of cases with the Japanese encephalitis. Uttar Pradesh is on the top. So just coming to the quick global perspective, worldwide, as I said, herpes virus is the most commonest one, herpes virus 1 and 2. Then varicella again is ubiquitous. Epstein-Barr is very common. Cytomegalovirus in the background of immunodeficiency or HIV. Human herpes virus 6 and 7 also pretty common. And amongst the enteroviruses, we had hand, foot, and mouth disease, that is enterovirus 71 and Coxsackie A1. So enteroviruses are also cause for a lot of the viral illnesses, which can actually have encephalitis as a complication. Measles and mumps, we have discussed about this. Measles can have three forms of encephalitis. One is the measles encephalitis, that is when the child has an acute infection, there is a direct penetration of the measles virus into the brain. The second one is basically a little late when it follows the measles infection, which is called measles inclusion body encephalitis. And the third type is basically a latent infection which stays inside the body for a long time, gets reactivated after years together. While I'm talking about SSP, that is subacute sclerosing panencephalitis. So the three forms of encephalitis which can be seen with measles. With mumps, you have a lot of spectrum of encephalitis. One thing is mumps encephalitis per se, and second is mumps-related para-infectious phenomenon like demyelination, and also can happen with mumps. And you can also have aseptic meningitis. With rabies virus, I think you can have rabies encephalitis following a dog bite. In the United States, not very common West Nile, Colorado tick fever. Dengue is also common in few parts of United States. And equine encephalitis, not very common in India again. It depends on the content which you are in. In the Asia, you need to think a lot of Japanese encephalitis, arboviral infections like dengue, chikungunya, Nipah. I'll not go into the details of other countries. So this is another interesting slide, that is what you need to know in the history. That is the first thing. Fever patterns are very important. If there is on and off undulating fever, or if there is evening rise of temperature, think of tuberculosis. If there is no relapsing fever, start thinking of brucella, borrelia, and atypical infections like that. The duration of progression of symptoms, for example, the onset of altered sensory was very subacute and then has fastly progressed in the last few days. Start thinking of acute bacterial infection, or on an ongoing or very slow type of illness which is going on since last few weeks. Think of tubercular autoimmune encephalitis. If you have the child has neuropsychiatric manifestations, like the child has become aggressive, has become calm, think of autoimmune encephalitis. The child has orofacial dyskinesis, think of autoimmune encephalitis again. And this is the same again. New onset seizure should point towards some parenchymal involvement like encephalitis. So meningitis patients usually don't have seizures. The moment you have seizure, you need to think there's something parenchymal. Focal neurological deficits, again, encephalitis. And etiologies about demography is very important. Recent travel to a hilly area, uh, to a crowded area with Tirupati and pilgrimage places. When you go there, you have a lot of viral infections happening there. So outbreaks are very important. So certain parts of India again has certain infections, like UP has Japanese encephalitis, Delhi has a lot of scrub typhus, Mumbai has a lot of leptospira. So this travel is extremely important. You need to know what are the outbreaks which are currently going on in the country. So the travel to that part actually gives you a clue what infection you're dealing with. Recent vaccination again. A lot of vaccinations are known to cause demyelination events, especially influenza can cause ADEM, it can cause ANIC, it can cause GVS, etc. Contact with animals extremely important. Animal bites or bat exposure, you need to think of rabies. Consumption of raw milk, you need to think of brucellosis, and uncooked meat as well. And contamination with unchlorinated fresh water, that is free water swimming, you think of primary amoebic meningitis. Contamination of animal urine, it's basically very poor hygiene. We can't actually get the history of poor the water contamination with animal urine. It's like whenever you have a lot of slum area, we have a lot of water which is not being cleaned properly. So there's a probable exposure of animal urine into the water. So leptospirosis needs to be thought. It's pretty endemic in Mumbai. So they usually present with fever, rash sometimes, and you have hepatorenal involvement. You have deranged liver enzymes and also renal involvement. So that's a typical history in leptospira. You also have hemorrhagic conjunctivitis in leptospira. So what you call Weil's disease. So needs to be thought when there's exposure to polluted water. Extremely important, exposure to mosquito bites. Again, we have a lot of arboviral infections, including dengue, chikungunya, and even malaria with mosquito bites. Tick bites, think of tick bite encephalitis and rickettsial fevers with tick bites. And More important is risk factors. For example, is a known case of retroviral disease or is on chemotherapy or steroids. Start thinking of atypical infections like Cryptococcus, PCP, etc. And pre-illness epilepsy, for example, a child is also a known case of epilepsy or he has a baseline developmental delay. You start thinking of a genetic cause or an involuntary metabolism presenting as an acute encephalopathy. It may not be an infection per se. So I'll not go into the details of the clinical presentation. These are the systemic clues what you think in the case of acute infection. So here, if the child has hepatitis, hepatitis E virus can also cause encephalitis. Start thinking of hepatitis, in hepatitis E and Coxiella. When you have generalized lymphadenopathy, start thinking of Epstein-Barr infection. Especially infectious mononucleosis will have cervical lymphadenopathy, splenomegaly, and HIV would have non-specific generalized lymphadenopathy along with pharyngitis. Acute seroconversion could also have sometimes lymphadenopathy. In CMV can also have lymphadenopathy, and in other viral infections you have generalized lymphadenopathy. When you have parotitis, think of mumps. Rash can be there in a whole lot of infections like strep typhus, varicella, rickettsial and other rickettsial infections, Lyme's disease. Target rash will be there in Lyme's disease. So these are all important clues in rash. And respiratory infections in Indian scenario, whenever you have an encephalitis patient coming to you with also bad chest and infiltrates in the X-ray, start thinking of influenza and adenoviruses. And diarrhea and adenoviruses, whenever you have conjunctivitis with encephalitis, think of adenovirus infections. And retinitis, CMV involvement should be thought of, retinitis plus CNS infection. And remember to observe other neurological findings. For example, few viral infections are known to cause altered sensorium and particular uh, localization like cerebellitis. In that category, start thinking of varicella involvement, Epstein-Barr, mumps. All these can cause post-viral viral cerebellitis. Okay, and the other ones I won't go into the detail. Not very common. See, these are some of the systemic clues in a case of CNS infection. So I won't go into the details of it. Clinical laboratory features of viral infections are clinical features again in meningitis. As I said, I think you need to differentiate first meningoencephalitis and meningitis. So in meningitis, you have more of the neck stiffness and the meningeal signs. And the neck stiffness, Kernicks Bull-Since will be positive. You have headache, you have photophobia, you have fever. But viral meningitis is more of a less severe form of involvement. So if you see the differences here, the ill appearance is more common in bacterial. The typical Hippocratic faces, what you see in typhoid is actually seen in bacterial meningitis. The child will be very irritable, very stressed. So all that will be there in bacterial meningitis. And in the physical examination, if you have petechiae purpura, that actually points towards meningococcus. So that also gives you a clue that we're dealing with bacterial meningitis. So CSF parameters, as you all know, in viral meningitis, you have cells which are predominantly lymphocytes, and they're usually typically 10 to 500. And in bacterial meningitis, typically the cell count is going to be more than 1,000, and it's going to be predominantly polymorphic, and that is extremely important. And whenever we have a bacterial meningitis, obviously the bacteria will consume the glucose. You have hypoglycorrhea, that is the CSF sugar will be lesser. And always make sure you ensure the fact that you do a random blood sugar when you're doing with a CSF blood sugar. It needs to be compared. So it should be less than 60% of the serum value, then only it becomes very significant. Or despite the serum value, if the level of the glucose is less than 50, and some actually say it's 40, then it is hypoglycorrhea that points towards bacterial meningitis. In the viral encephalitis or meningitis is not that affected. The glucose is going to be pretty normal. Then coming to protein will be extremely high in bacterial meningitis, and it's going to be extremely uh, high in tubercular and bacterial, whereas in viral it's going to be elevated but not that significant. So this is one slide which is extremely important. You cannot exclude meningitis, you cannot exclude encephalitis when you say that the physical exam does not show meningeal signs. So whenever you document that there's no meningeal signs, it doesn't say that you're ruling out. So you need to know the sensitivities. If you see fever also has only 85% sensitivity, that means you can have a CNS infection without a fever as well. So neck stiffness in case of meningitis, the sensitivity is only 70%. Altered sensorium is 67%. And Absence of all three, that is fever, neck stiffness, and altered sensorium. The sensitivity to rule out is 90 to 99 to 100%. If you have all three not there, then you can be pretty sure that you're not dealing with CNS infection. But each you need to know the sensitivity. Kernix, if you don't have Kernix and you can't rule it out, again, as I said, you need to do the whole examination and then do it. There's a new sign which is called Joel's accentuation test. It's a brand new meningeal sign. I'll discuss that in the coming slides. It has the highest sensitivity, almost nearing to 100%. So Joel's accentuation test, basically you ask the patient to shake the head side to side rapidly. This will only happen if the patient is cooperative. So it's typically seen in adults and adolescents. When you shake the head rapidly from side to side position, you have severe headache. So this is again because of the pressure and the shear you're creating in the meninges. That causes severe pain. So if that is there, it is suggestive of meningitis. It's not specific for meningitis, but it's highly sensitive for meningitis. So quickly about the meningeal signs, Kernig's sign, you flex the hip at 90 degrees and you start holding, support the knee, and you then flex, so extend the knee joint. So this will be very difficult to do because when you do this whole procedure, there is stretching of iliacus muscle and iliopsoas muscle, and that is actually connected to your posterior vertebral, posterior region of your abdomen that is connected to your anterior vertebral region, which is very close to meninges. So when you do this maneuver, the meninges actually get stressed. So that is the reason why you have pain and difficulty in doing this. In Brzezinski, you have two type of tests, that is Brzezinski neck and Brzezinski leg test. When you flex the neck, you have involuntary flexion of your hip and knee, and vice versa for the knee sign. So these are other meningeal signs like nuchal rigidity, Brzezinski. Spine sign is basically the child when he's in the sitting position, it's very difficult for him to bend. He will have a lot of pain. And what is this? This is called Amos sign, that is tripod sign. The child feels comfortable sitting in this posture. This is typically also seen in acute epiglottitis. Uh, that is again because of the meningeal irritation, so they get comfortable in this particular position. Other less common signs, that is Lasik sign and Koenig sign, also we have discussed this before. So this is the sign I was talking about. This is a typical tripod position wherein the child is comfortable in this position because they'll have the least resistance for the meningeal stretch. So this is pretty non-specific. It's typically seen in acute epiglottitis, but can also be seen in meningitis. So this is a test I was talking about. This introduced later in late 90s. I think this is called Jolt accentuation maneuver. Ask the patient to rapidly rotate his head horizontally. The headache worsens. The sensitivity according to them is 100%. Specificity is 54 because any sort of ixol or any sort of meningeal irritation will produce this pain. So this doesn't point directly towards meningitis, but it points towards some pathology. So sensitivity is high. The specificity is not that high. So this is again the incidence. I won't go into the details of it. So also remember, there are few causes where you need to think it looks like meningitis, but not it is not meningitis. So this is called meningism. So there is a stiff neck, there is Kernig's positive, but there are no other signs of CNS infection. The MRI is normal. So here you need to start thinking that tonsillitis also has complications like peritonsillar abscess. It touches your posterior pharyngeal wall, is very closely in contact with your anterior vertebral region, the cervical region that close to meninges again, and that can produce meningism. Retropharyngeal abscess, severe otitis media, again irritating meninges. Severe pneumonia with pleuritis can also have sometimes. So these are some of the signs. Dystonic reaction also, like some of the medications are known to cause dystonia. Sometimes that can also be confused with meningism. And one more thing is basically tetanus. So tetanus also, you have log and rigidity. Sometimes it can be misunderstood as meningism. So this is the approach. I won't go into the approach of it. And also the complications are outlined in this picture. So it depends on what type of organism or what type of bacterial or viral meningitis we're dealing with. It depends on that. It will go into the complications of bacterial meningitis. So quickly and onto how to evaluate a child with bacterial meningitis, how to evaluate a child with viral meningoencephalitis. That we'll discuss in this next few slides. So typically, whenever we have a child with suspected bacterial meningitis, the child is less than 1 year. So any child who comes to you with fever, altered sensory with seizure, you need to think it could be CNS infection. Every fever in infancy won't be febrile seizure. You need to rule out a CNS infection. Also remember in infancy, meningeal signs are not well appreciated. So you need to rely completely on the patient's irritability, drowsiness, and CBC and your counts. Try to find the focus, and then if you're not still sure where is the focus of the fever, it's better to do a CSF analysis. So there are various guidelines which are put forth by American Academy of Pediatrics and IDSA. So any child is less than 6 months. So some of the bodies actually tell you to mandate CSF analysis whenever we have child with seizure and fever. So the initial evaluation should include, routine bloods like, CBC with differential count and platelet counts. Blood culture needs to be done. We try to find out where is the infection, get a urine routine done, get a CRP and procal, serum electrolytes to rule out other causes of seizures. If you don't find any reason, LP should be performed in all children with suspected meningitis. So LP should be sent for routine analysis like cell count, protein, and sugar, and then to specifically identify if the LPs, if the analysis is abnormal, if the protein is high or glucose is less, if the cells are high, then you should go for analyzing what type of organism are you dealing with. So in that condition, we can either go for culture, we can go for PCR, we can go for metagenomics. So we'll be discussing that later on. And next, imaging is also extremely important in infections. So if you're suspecting clinically an encephalitis, imaging is more important than LP itself. So make sure if the imaging is going to take time, do not delay your antibiotics because there's 1 day time for an appointment for an MRI, or I want to do LP after MRI. If you're suspecting a raised ICD, I want to do MRI first and then do LP. So the whole procedure should not delay the process of starting antibiotics. So empiric antibiotics should be started if the imaging and LP are getting delayed. So the priority needs to be given to the brain, not the diagnosis. So this is a short algorithm onto how to treat acute bacterial meningitis. That if you have any child who's less than 3 months, I mean, if the child is less than 3 months, if the child is ill appearing, immunocompromised, on examination is petechiae purpura, there's recent history of any surgery, and any of these are there, and if you're suspecting that there's meningitis, prediction scores are very high, empiric antibiotics should be immediately started. Or to determine if there's the risk of meningitis, then you analyze CSF. If the CSF gram stain is positive, the CSF neutrophil count is high, the CSF protein is high. This basically is an algorithm to basically diagnose. Basically, if there's these clinical features of meningitis, you start doing neuroimaging and CSF. If one of that is positive, you can label the child as meningitis and start treatment accordingly. So this is one of the investigation we talked about. I think in the last in the decade, this is the most used test. This is multiplex PCR. So the first company which came up with this is called the BioFire Diagnostics. So the test name is not called BioFire. BioFire is actually the name of the company. So the test name is multiplex PCR. As the name itself says, there's a simultaneous detection of various viruses by the principle of PCR. So there are various panels of multiplex PCR, like that can be bacterial, viruses, or only fungi. But there's a common panel which includes meningoencephalitis panel. Depends on the company which you're doing. So all of that will be covered in one panel. So not that cheap. It comes again. It's pretty expensive test, and it only looks at these organisms. It's a common causes of meningoencephalitis. If we find the cause, well and good. It will help us in tapering our treatment and deciding the duration of antibiotics as well. So typically, if you see the amount of time which takes, the turnaround time, what you need for BioFire is basically very less. So it only takes around few hours for the test results to come if the lab is actually well functioning. So here, what you need to do, the CSF sample needs to be sent to the sample to the lab, and there's a rapid test which is happening, and traditional targeted PCR is done within few hours, and immediately the report can be usually reported within the same day. So that's an advantage that PCR can be done very soon. So another advanced test is basically what we call as metagenomics. Metagenomics is the newer version, the newest test what we have currently available. So metagenomics is basically a technology which is called Oxford nanopore technology. So this is long-read sequencing of bacterial or viral DNA. So the sample is taken up and it will detect all the microorganisms depending on what you send. If it's a bacterial panel, it's going to look at approximately 25 to 30,000 bacteria in the sample which you're sending. And it's going to sequence the bacteria. So that's going to identify. And not only that, it will also give you the resistance genes. So based on that, you can actually predict whether this bacteria is going to be resistant to certain antibiotics or not. So metagenomics is actually more advanced than multiplex PCR because first thing, it can identify a bigger chunk of bacteria, like all the bacteria. When compared to multiplex PCR, you have fixed number of bacteria. For example, if you have a rare cause of bacteria, multiplex PCR won't be picking up. Metagenomics will definitely pick up. So in that way, it's advantageous, and the turnaround time is also not that high for metagenomics. It's going to be around 24 to 48 hours within the same day. Usually, the entire sequence, the entire bacteria will be sequenced. The second thing, it can sometimes pick up contaminants. It can sometimes pick up, commensals. So when there are multiple organisms picked up, polymicrobial causes there, they'll also give you the percentage and the probable likelihood of which is going to be the pathogenic, which is going to be a normal commensal. So it also comes with few disadvantages like picking up a contaminant again will give you a lot of confusion and the transport. There are a lot of other logistic issues, but overall, I think metagenomics is a very go-to test in the current generation. Not very expensive. I mean, not it's very expensive, but it's almost like the multiplex PCR. So I think we can stop here. I think the second part of this lecture would be more on neuroimaging and treatment aspects. So in the second lecture, it will be a lot of case scenarios wherein you have typical real life scenarios with neuroimaging, and it's going to be more of interactive wherein what are the differential diagnosis based on the neuroimaging. So we'll discuss that in the next lecture. Thank you.